Wall. That was really great. And we've got, well, our doctors have been very busy answering more than 100 questions, and we've got another 40 to go so far. And there are quite a few for you as well. So I will ask Tracy to take it away. Tracy?
Okay, so maybe I'll start out with some of the questions. Maybe Dr. Wall can answer some of the easier ones in the Q&A. So I'm going to start with some of the ones from our Spanish attendees so that they can get some translations. So I have one from patients in Bolivia, and they have a significant group of families with hereditary amyloidosis in that area, and they're wondering what can they do to catch the interest of investigators and laboratories, etc., to help? Do we have any ideas from our panel?
Just raise your hand and we'll call on you, right?
Or somebody can start and then the others can raise their hand.
You know, something I might suggest just briefly while you're waiting for someone is that Dr. Marcia Waddington Cruz in Rio de Janeiro has a hereditary center, hereditary TTR center there. And I don't know how many of our patients in South America, other than in Brazil, are aware of her, but maybe they could contact Fabio Figueroa from the support group there, and maybe he can give them a little help as to how they got started there with their research center.
And Dr. Walensky has his hand raised. So, Dr. Lewinsky? Oh, is he muted?
There are a lot of, can you hear me?
Yeah.
Yep.
Okay, good. There are a lot of conferences in Latin America and South America that focus on imaging. One is called ALASBA. There's also some Latin American cardiac imaging societies, and many of these have a focus on imaging, MR, PYP imaging, PET imaging, with reference to what Dr. Wall has talked about. If you could get some of your local heart associations to work with some of these societies to reach out to bring in more speakers to speak to the general heart failure doctors, that may be a way to increase interest and maybe then get some of the researchers to attend other meetings in the United States.
Another one that probably affects, this is relevant for a lot of patients, is about suggestions to eat better, but also gain weight. I think it was also in relation to those that have GI impacts of the disease.
We don't have any nutritionists or GI doctors on the panel. But, fellow patients always seem to have the good suggestions on what they do to gain weight. And I see that all the time on our Facebook group. They're always offering suggestions. Paula? Paula's, okay. But so what I'm suggesting is perhaps they might want to join our Facebook group for ATTR, and then they can find out from other patients what they're doing. And we will try and get, if on our next webinar, we will try and get a gastrointestinal doctor, a GI doctor, and we'll try to get a nutritionist as well on there. Maybe we'll get one, maybe we'll get both. We'll try though.
Okay, I have one about nerves. It says, when the axon is broken, is it possible to regenerate or induce the production of new neurons in the peripheral system, or this process occurs naturally? Dr.
Keku or Dr. Karam?
So I think Dr. Karam actually addressed this a little earlier, but there's sort of two different, I
see that.
Can you hear me?
I don't hear.
Yeah.
Okay, so there's sort of two ways that the nerve can be affected. It can be that outer fatty covering called the myelin, or it can be the actual nerve, which is called the axon. So when the just the myelin covering is affected, oftentimes it's much easier for the nerve to regenerate, to grow back, for the body to help repair itself. Whereas If you have axonal damage, which is the actual interior of the nerve, it depends on how long the damage has been ongoing and how severe the damage is. There is potential to help regenerate. However, sometimes when it's been ongoing for a really long time, the damage may unfortunately be permanent. Dr. Crum, did you want to add anything to that?
Oh, beautiful explanation. But I think the other part of the question was, is there something you can do yourself? And unfortunately, there's no type of supplements or medication that has been shown to kind of sprout these axons or help them regenerate. But what is the most important is to stop whatever is causing the nerve damage. And in ATTR amyloidosis, meaning try to use the medication that are approved for treatment for this condition, and as well as avoiding any other type of kind of toxicity to the nerve. So some medications that you may be on may be toxic to the nerve. Sometimes if you drink too much alcohol, that may be toxic to the nerve. Some people also have amyloidosis and diabetes, and you have to control the diabetes. So there's many different reasons that we have to control to give the nerve the best chance of kind of the body recover itself. But yeah, unfortunately, a lot of time the recovery is not 100%. And if the disease is advanced, the recovery is minimal.
I would also just add to that in addition to things like diabetes, your amyloid neurologist may want to check for other risk factors that may be contributing to neuropathy, just to help your body, itself help repair the nerves. So that involves checking things like your thyroid function, your vitamin B12 level, various things like that, making sure there's no additional toxicities, as Dr. Karam said as well.
Thank you.
Sure.
So my next, it's more of a group of questions, and so maybe multiple doctors want to answer these. I think there are also some from our Spanish colleagues about green tea.
Can you speak up, Trace?
Yeah, sorry. Multiple questions around green tea. And so maybe we have a few different doctors answering, but we had questions about, I guess maybe I'll just ask them one at a time. I know that some of them were answered in the answer section, but since there were so many about this topic, I thought maybe it made sense to cover it. So the dosage, if I remember correctly, in one of the answers, I think Dr. Walensky, it was 250 milligrams. Is that right for the green tea?
So, the studies are about 250 milligrams twice to 3 times a day. You have to realize that these are small studies, so the doses have not been tested in this. Also, there is some data that suggests either echocardiographic changes or mass changes in the size of the LV mass, but they really haven't been correlated to that great a degree with functional changes. So this is all, very, very preliminary. On the other hand, there is no toxicity to it, and it's a lot easier than drinking 1 to 2 liters a day of green tea. You do have to remember that there's some caffeine in it, so you may, if you have AFib, you may notice that. But other than that, there's very little side effects to it other than the caffeine that's in it and some of the GI side effects that you could get from it. You buy this, of course, over the counter in a health food store or anywhere else. It's not a prescription, and it certainly should be readily available anywhere around the world.
And you mentioned the caffeine. Oh, sorry. You mentioned the caffeine. So, because one of the questions too was about arrhythmia. So, is there any cause?
Tea has less caffeine in it than coffee does. And it's the likelihood of people getting symptoms from tea, particularly because they use green tea for kind of health reasons and well-being reasons, that I've not really experienced any significant side effects of it.
And then there was another question about when to take it. Is it before eating or after eating? Does that have an influence?
I don't know. Maybe one of the other panelists do, but I don't know of any interaction with meals, nor do I think it's been studied.
Hello, everyone. This is Farouk Sheikh from Georgetown Washington Hospital Center.
Speak up, Doctor.
Yeah, you're kind of quiet.
Can you hear me now?
Oh, that's better.
Okay, great. So thank you for the invitation. I would agree with Dr. Walensky's last comment. It has not been systematically studied.
You're fading out. You're fading out.
Now? Is it better now? I'm having some Wi-Fi issues. I apologize.
I'm going to turn up my volume. Maybe I'll suggest to everyone they turn up the volume on their.
Is this better?
Yeah.
Okay, excellent. There is not good data to discuss or to define the timing of the drug therapy, meaning before or after meals. I do not think that we currently know whether it plays a role. I wanted to echo Dr. Walensky's comment regarding the observational nature of the findings. That meaning that the studies were non-randomized, again, open label. I think the paper that gets cited all the time is Kristen and colleagues in Germany and Europe from like 2012. And it's a very provocative finding related to one of the compounds in green tea.
Dr. Sheikh, you're fading out on us.
So sorry. Let me see if I can fix that. I'll try to fix that. I'll call back.
Okay, sorry.
Okay, great, because we do have a question for you. Someone wants to know if you're married.
I think you already hung up. Okay. So we'll wait for him to call back and maybe he can cover some more about the green tea. So while we're waiting for that, there was a question about lungs. So there was a presentation today and experts had mentioned or posted on the slides about the location of the amyloid and of course various organs, and nobody is mentioning lungs. And we had a patient who asked if that's having amyloid in the lungs is this person an odd duck? Are they the odd of the odd?
Dr. Picken wants to answer that one.
Yeah, right. I think I attempted to provide a written answer, but lungs are actually quite frequently involved in many types of amyloidosis, systemic, that is. So it's not only in light chain amyloidosis, but also in transthyretin, both hereditary and wild type. But the reason why there is less talk about lungs with regard to the hereditary and wild type amyloidosis is that the clinical image is usually overshadowed by cardiac or polyneuropathy involvement, but there is definitely pulmonary involvement.
Thank you, Dr. Picken.
Thank you.
And you did answer it on in there. You did that. Yeah. I just wanted to, sometimes just for everybody to know that even if you answer the question, people may not see it. And
Tracy, I did see it while we have Dr. Picken. I did see another question from one of our Gelsern patients wanting to know how Gelsern amyloidosis is diagnosed other than DNA test. Is there a way to do that?
Yeah, I mean, the dogma as far as amyloid type determination is concerned, that it has to be done based on the actual deposits. So usually the presence of a mutation in itself is not 100% diagnostic of the amyloid type. It frequently does correlate, but you need to have amyloid type determination based on the deposits. So it's high likelihood, but not 100%.
So with a Gelsern patient, can you do a fat pad biopsy, or do you have to biopsy the organ, and then would you send it for mass spectrometry? Is that what you're talking about?
Yeah. Yes, you need to have tissue with amyloid and have determination, most likely with mass spectrometry. Now, the sensitivity of fat for Gelsern amyloid has not been determined in the wide studies, as it was mentioned before. I think Dr. Walensky showed a graph which shows that the highest sensitivity for amyloid is for light chain amyloid, AA amyloid, and then for hereditary transthyretin about 60%. And there are just sporadic reports about Gelsern. And I cannot give you a number, probably lower. So
Okay,
fat may not be positive.
gotcha. Okay,
Okay.
Tracy, any more?
Let's see, next question. This one was already answered, but I also thought it was important for all to hear. So the question was about what type of doctor to see. So many AL patients go to a hematologist or an oncologist, and what's the recommendation on where TTR patients should, what type of doctor they should see?
Doctor?
So I think that, the bulk of patients with TTR have a cardiac component, and most of these people die of cardiac disease. And the definitive test, non-invasively, is a cardiac test. It's been my experience that neither neurologists like to do, nor do patients like to have nerve biopsies done. They would much rather have a non-invasive cardiac test. So certainly if there are cardiac symptoms, they should see a cardiologist. But I think that's really speak to the advantage of an amyloid center. If you look at the data from amyloid centers around the country, where it's very easy for somebody to see more than one doctor in a given day, or make sure that they get sent to the right doctor very easily without having to go back and be re-referred and things like that. So I'd argue it's not which doctor, but what kind of center to be seen at.
Okay.
And someone, I think, is Kara Rosenbaum on there here? Because she's a hematologist, and I'm sure that they get a lot of patients that don't know their type, and then they have to kind of triage them and figure out where they're going to go. Is Dr. Rosenbaum on here to answer that?
I'm here.
Dr. Rosenbaum, do you get any TTR patients that you have to give to a cardiologist or neurologist? Or?
Certainly, and we're intimately involved, and that's why I wanted to join today, and mostly so in the diagnostic, especially in the diagnostic phase, where a patient, at least before TTR is becoming more and more detected early, a community physician will usually send to a hematologist, and even with TTR, I mean, we know that there's reports of up to 50% of these patients can have MGUS, which will also be sent initially to a hematologist who may actually be doing the workup, for the amyloid in general and diagnosing TTR. So I think, that's why we need to be involved. And I think that's going to be harder in centers that don't operate as an amyloid center, where logistically it is hard to coordinate. And I think that's, the goal moving forward is really having that.
Right, and I just noticed Dr. Sanchirwala is on here too, and I know that she just reminded us that that Amazon, and this is not, we don't own stock, well, maybe she does own stock in Amazon, she's a doctor, but I don't own stock in Amazon, and I can tell you that they do have caffeine-free green tea extract on Amazon. I don't know if it's as good as the stuff with caffeine. Sometimes when you take out caffeine, you take away the flavor of things. That's what people tell me anyway. But anyway, so, and Dr. Sanchirwala would also see quite a few, I would imagine, amyloidosis patients at the Boston Center that they kind of have to triage and figure out where they go to. Dr. Sanchirwala, are you there?
Yes, I am. And, I work in a multidisciplinary amyloid center. So, I think our approach is very different, that the patient, when arrives with a diagnosis of amyloidosis, we end up seeing them for, in a true multidisciplinary way. They spend 2 days in Boston, and they are seen in one clinic by all the subspecialists, including hematologists, cardiologists, neurologists, nephrologists, and also pulmonologist or Dr. Burke. So, 2 days are spent, all the testing is done, and then a multidisciplinary clinical team meeting is held on Friday, where we discuss the diagnosis and treatment recommendations, which are relayed to the patient and referring physician on Friday afternoon. So I think that, obviously it's a biased opinion, but I strongly believe that, that to able to get proper diagnosis and treatment recommendations I think it is important for a patient to be seen at a center and then can be, at least, and enroll on clinical trials or at least have a proper treatment recommendation. Again, most of the panelists, they all have multidisciplinary groups. So I think it does make a difference. And I think I'm hoping that, the panelists would agree to that as well. I think it is difficult for a patient who's not feeling well to really see 5 different doctors over 3 months, over 5 months at different clinics and different institutions. So I think it is crucial that it is done in a more cohesive and comprehensive manner.
Thank you. Tracy, any more questions?
Yeah, so I have one here. It says, I have been on tafamidis for 15 months, now doxycycline for a month. Intention was to be part of cardio T-transform, but screened out from poor kidney function. Any idea what I can expect over time? Anything I should watch out for other than the sunlight, which they're aware of the issues with sunlight? Is there any way to measure the effectiveness of this combo treatment? Okay, any volunteers to answer?
Any of our pharma people? Notice that they're kind of shy. They like writing their answers, but they don't like speaking them. I wonder why that is. They have to check with their legal department probably before they answer any questions I got, right?
Hi, this is Michaela from Ionis.
Hi, we have an Ionis person, yes.
Yeah. So I think the patient he's asking, this is question more for physician, because the patient screen failed for cardiotransform due to renal function. So he's asking, is this combination therapy with tafamidis and the other drug is effective when we will see the data? So I will let the physician talk about this. For cardiotransform, unfortunately, renal function is part of the exclusion criteria. So if you have a renal function below GFR of 30, you cannot qualify, you don't qualify for the trial. Of course, there is always the option to rescreen the patient, and this can be discussed with the doctor.
Thank you. We have 49 questions that haven't been answered by our panelists yet. So, and I know you've been working very hard, panelists, but we hate to see anyone, leave our program today without getting an answer. So, and I promised everyone they would get an answer. So please help me keep my promise, okay? Tracy, any more questions?
Okay. So how, one of the questions is about wild type. So it says, how does wild type TTR typically impact expected length of, or the life expectancy? Yeah. So wild type TTR and life expectancy, if there's anything that we have there.
Oh, was it specific about life expectancy? Well,
yeah, I don't know if there's anything we have. It just says, how does wild type TTR typically impact expected life? Okay. Length of life, so life expectancy.
There would be 2 answers to that, right? Let's have one of our cardiologists answer this. You would have those that are on treatment versus the usual, the studies before there were any treatments on wild type. And then again, you don't know when they were diagnosed, how far into the disease they are. But let's have Dr. Sperry, are you in here? Or Dr. Patel, are you there that can answer a question?
Yeah, yes, I'm here.
Oh, wait, we've got Dr. Patel here. So we're looking at Dr. Patel. Oh, I love your background. Oh, there's Dr. Sperry. You've got a boring background, Dr. Sperry.
Brett, why don't you take this one?
I'll have to figure out how to change my background here. Well, the question was, what is life expectancy? And I imagine Dr. Walensky talked a little bit about this, but especially in looking at the ATTRACT study. But it's hard because this is a question that we often get from patients, and it's really hard to, give you'll never know exactly how much longer you have here. And I think we've all come to terms with that with the coronavirus situation that's going on. But, in the studies that were done, on average, with wild type, people lived between 2 and 4, 2 and 5 years. Now, some of those studies that a lot of us participated in were enrolling patients. Even 5 years ago, the intuition of cardiologists and other doctors to look into and to find ATTR wild type early, is not there. So this is getting better and better. Hopefully, over time, as we keep diagnosing people earlier and earlier in the stage, that the duration of life increases, and also with the various medications that are available now, most specifically tafamidis, which is FDA approved now, that time will continue to lengthen. So, short answer, we don't really know. What's been published has been anywhere between the 2 and 5 year range. And we think with medications and with earlier diagnosis, that will continue to increase.
Good
I'd like
answer.
to echo what Brett said. I mean, this is probably the hardest question that we get asked. And I think the answer is that the data we have probably represents the worst case scenario. At the people who came to biopsy and treatment were probably all advanced class 3 patients. And that finding people at class 2 and class 3, modifying standard therapy and adding on approved therapy and clinical research trials, that we would expect that the prognosis would be better. But that does not deny the fact that this is a serious disease, and making them understand the balance between being hopeful and being realistic is difficult.
Mm-hmm.
Thank you. Okay, Tracy, next question.
Yes. One of the questions was about COVID-19. Of course, that's on a lot of people's minds. So is there any suggestions or guidance around testing for COVID, because maybe we consider the TTR patients higher risk, wild type, or any of the other subtypes, and should they be asking their doctors to get COVID-19 tests?
Are they talking about the test or the antibody test, or they're not being specific on that?
No, they just ask about the COVID-19 testing. I presume they're asking whether they should be checking to see if they have it because they're at higher risk.
Yeah, I can take this question. The difficulty with testing for COVID infection, and that would be using one of the tests that detect the virus itself, or a PCR test, is that just doing sporadic testing really doesn't help, particularly if you're asymptomatic, because you could be negative one day and you could end up with the virus 3 days later. So it's impractical to be tested on a regular basis for the detection of the virus. Now, the hope is that we will be able to look for antibodies in the blood to the virus, which would indicate exposure to the virus and whether you've had an infection or not, presumably asymptomatic infection, and you've developed some degree of immunity. But these tests are currently undergoing validation and evaluation. And we don't know whether these antibodies are protective. In fact, the World Health Organization today reported that it's possible that patients can get coronavirus more than once, which is more concerning. So while amyloid patients are potentially at greater risk, particularly if they have a history of heart failure, and given the age, the general recommendation is to continue to use social isolation and strict hygiene measures to minimize risk of transmission. And even once we start opening up our economy, as certain states have, patients at highest risk should be the last to be able to be going out into the public. And I would recommend that everybody wear a mask when they're in company with other people, and keep a 6-foot distance.
Yeah. And
okay,
also,
I just put on my mask. I want everyone to see that, okay? And also, I want to refer all of our COVID-19 questions to our chat, where Dr. Vishali Sanchuela, a newly elected officer of the International Society of Amyloidosis, we might add, posted the link to the guidance by the International Society of Amyloidosis for amyloidosis patients. So that would be very valuable for everyone to click on that link and read it. It is available to everyone. It is an open article. Some of these are closed, but this one is open to everyone.
Muriel, can you remind me which doctor we were talking about with the green tea? Maybe we can see if he came back and talk about.
Was that Dr. Walensky?
No, it was a different.
It was me.
Dr.
Yeah.
Shake. Dr. Shake, he's back. Yay.
It's a little better in terms of volume.
Yes, much better.
So I think we left off simply asking or following up on the subsequent question about the timing of green tea extract. And what I was saying was I do not know of definitive data as to the timing as it pertains to, taking it before food or after food. So I do not believe we have a definitive answer, and I do not believe that there's risk one way or the other or theoretical benefit. I echoed many of Dr. Walensky's comments regarding, the theoretical benefits and the relative lack of downside of taking the medication. Remember, one of the compounds within green tea extract, the EGCG, is what's thought of to prevent the amyloid fibril formation or prevent its deposition. And then I think that additional point that we were making was that the original data, as opposed to or juxtaposed or compared to what we know about tafamidis, which was rigorously performed, that analysis and trial was done in a randomized double-blind way. The data with green tea extract is observational. It's single center and observational. And so we have to take that with a bit of a grain of salt, albeit when patients ask me about it, we are fully supportive of it. In fact, many patients with tafamidis are simultaneously taking the green tea extract, and we have not identified any harm related to that.
That's right. The first study was actually an AL doctor, Dr. Holstein from Germany, and he drank gallons and gallons of it, I understand, but he had also had a stem cell transplant, and he claimed that his heart wall lost maybe 3 millimeters of thickness. I'm not really sure what the measurement was, but one could argue that it could have been a result of having had a stem cell transplant and his body was kind of healing on its own. So do we have data in TTR or only the AL from Dr. Holstein's group? Dr. Shake?
Sorry, I apologize, I was on mute. There is data in ATTR amyloidosis as well as AL. Much of the data comes from Europe. I had mentioned, I think this is where my voice had unfortunately trailed off. Dr. Kristen and his group in Germany, I think, have sort of the paper that is utilized most often from 2012 or 2013. And then again, some single center observational data. I think it will be interesting, our center amongst probably other centers are now collecting data on patients who take green tea extract. Of course, it's all observational and unfortunately not randomized. So even the conclusions we make with it will be have to be taken with a grain of salt. So I think we'll have more data in the next couple of years. But getting back to the original comment, the downside, low in caffeine content. So again, echoing Dr. Walensky's comment, I have not yet seen an exacerbation of arrhythmias with the drug. I think that the relative downside is extremely low.
And
I wonder if they have any green tea factories in Germany, that the Germans seem to be behind the push on the green tea extract so much.
I would have to ask the investigators. I don't have an answer for you on that.
Tracy?
Yeah, so you answered, Doctor, you answered one of the questions about tafamidis. The other one I had about green tea was absorption, and maybe there's no information there, but anything to improve absorption?
It's a really important question because, as we all know, many of our patients with amyloidosis suffer with malabsorption and can have difficulty absorbing medications and or food. I do not know of any data that can, increase the absorption of compounds like green tea extract. Getting back to the original comment, I do not know of an association with or without fluid or food that can improve the absorption. I think one of our goals as heart failure cardiologists is to particularly make sure we maintain patients in what we say a euvolemic state without additional retained fluid in the body, which can affect absorption of all of our medications. And so that's one thing where, collaboration with a cardiologist, a doctor who is an expert in assessing that patients are well compensated from a heart failure standpoint probably helps the absorption of all medications that amyloid patients take on a daily basis.
Okay. So I have a question here from Latin America. So they're asking about access to the medications like tafamidis and Onpentro and Intertierceran, and with the cost and other factors, they find it quite difficult to access the medications in Latin America, and they're wanting to know if there are any plans or anything going on to change that in Latin America as far as the availability of the medicines.
Well,
I'm not sure.
The answer would come for tafamidis from our Pfizer people, and for Onpattro would come from our Alnylam people, and Intertierceran would come from our Ionis people. So if they could answer that question, that would be really great. Can we have any one of you on live to answer that, or you?
I'm Muriel Craig from Pfizer.
Thank you, Craig.
Folks on the call today are US based, so we can only speak to the US business. But if that person wanted to send their information to you, you could pass it on to us and we'd make sure that they would get an answer.
Thank you. Any questions that don't get answered today that Craig brings up a very important point, and that you absolutely want an answer on, I would think that would be all of them. You can send that question, email it to either Paula@amyloidosissupport.org or Muriel@amyloidosissupport.org, and we will forward these to the people that we know can answer the question. And I promise you, they will get answered. Thank you. Thank you, Craig. And we've got 55 questions that haven't been answered yet. So we're going to be doing a lot of emailing, Paula and I think.
This is Kelly Capicelli from Alnylam. We are currently approved in Brazil for Onpattro, and they just have to speak to their physician, but the rest of Latin America has not been approved yet.
Is there a plan to get them approved in other countries in Latin America?
We're working hard to get as many approvals as we can. So
can you speak to which countries you're working hard to get approval on?
Not currently. I'm limited. Thanks.
Oh, see, okay, there you go. We got some information, right? But send us an email again, folks, and we'll get answers. I promise.
I am working on this for a couple of patients in my clinic who are international. And if and when I get any answers, I will forward them to Muriel and she can pass them on to everybody.
Thank you, Dr. Walensky. That's right. Being in Florida, you're easier to get to for those people in Latin America. That would make sense for sure. Tracy, next question.
Okay. We have some questions here about symptoms. So one of them was about losing voice or difficulty to talk or low volume in voice. Could those be symptoms of TTR? Well, actually they're asking, hereditary TTR, so they're not specifying which type.
Losing voice.
I think I've typed down the answer for that question, but happy to answer it again. Definitely certain type of amyloidosis can affect the vocal cord, the phrenic nerve, etc. So, but again, these symptoms are not specific. So, the doctor seeing you need to kind of address this, assess it, and determine whether this is coming from amyloidosis or something else.
Okay.
We have a question here. I do want to address it though. I recently had carpal tunnel surgery and ulnar decompression surgery, tested positive for amyloid through Congo red stain, but I have Gelsern type. When are we going to pay attention to the Gelsern type as more than minor for amyloid? And let me answer that, and because it was stated so beautifully by Dr. Havasi, and it was even touched upon by Dr. Karam, and that is that there are no treatments for this type of amyloidosis other than organ transplants and treating symptoms. So, and because it's that way, it's not that you're being ignored, it's just that they have no answers. And I think our hereditary TTR folks that have been around for a long time or saw their parents go through what they went through totally understand what you're going through, because that was them 10, 15, 20 years ago, even 5 years ago to a certain degree. So I do what we can do is hope that 5 years from now, we'll see some great changes there. But because you are the rare of the rare, we have to face what is. And what is right now, unfortunately, there just aren't any approved treatments. So with that said, we have to work on symptoms and organ transplant. Any doctors want to add to that? No? Okay. Thank you. Tracy?
Yep, and actually to build on that question, I have a couple for Dr. Wall. So actually related to Gelsern, there was a question about whether it would be useful to have this scan done for, based on the comments just by Muriel. Would it make sense to have it done for somebody who's got Gelsern?
That's a question for the clinicians to answer. If there's any benefit in knowing the distribution of the amyloid in the patient specifically for a clinical reason, then perhaps yes.
Okay. And do you have enough? Another question: do you have enough TTR patients, or do you need more to be? And how would one sign up if you need more?
Anyone can email me. That's the best way, using the phone. I normally don't get to the phone at all, but if you can email me, we will get in contact with you, take your name and send some material out. And yeah, we're still recruiting TTR patients and AL patients and all the LEC2 patients and all of them.
And then what about asymptomatic?
One thing, Trace, I have to say one thing for our Gelsern patients and our APOs and fibrinogens, where there are no treatments other than organ transplants. If you're curious to see where else you might light up, maybe you were told that you only have involvement in one organ, but you're kind of curious to see if another organ is involved, that might be a reason to get imaged. Another reason is that you're helping research. You're helping Dr. Wall in his research, which many people are going to be benefiting from. So if in any way you feel like being altruistic and helping others, that would be a way to do it for sure.
Yeah. Another one, Dr. Wall, is whether or not you picked up spinal stenosis in the imaging, because I think some patients have that also.
That's a great question. So in some of the patients, we do see, well, in some of the AL patients, we see obvious bone marrow involvement in the spine. And in some of the TTR patients, there are indications, although it's equivocal. So we're still working on understanding what the images look like around the spine, yes.
Okay. And are you taking asymptomatic? I think that was in here somewhere. They were wanting to know if you want asymptomatic patients that TTR.
Yeah, so we're about to amend the protocol that will allow us to image 10 asymptomatic TTR mutant carriers, yes.
Okay.
There will be specific criteria for those people, but yeah, we want to include them to see if we can detect it in asymptomatic carriers.
Oh, Dr. Wall, there was one question for you. Someone wanted to know if anyone ever asked you if you reminded them of Elton John.
Only in my bathrobe, Muriel.
Thank you. I come up with the important questions.
Yeah, I don't remember seeing that one, but all right. We mentioned earlier about one of the patients talked about sunlight, and they said they were aware of it, and we had a patient ask a follow-on question, and just please correct me if I'm wrong, but the topic of sunlight is related to TUDCA, right? And you have to be careful about exposure to the sunlight if you're taking TUDCA. Is that, no?
I thought it was
Please
Dr.
correct me.
Cycling.
Please correct me.
One of our doctors answered this.
Walensky, you're muted. There you go.
Doxycycline.
Yeah.
Oh, doxy. Okay.
Doxycycline.
Okay, thank you guys. So doxycycline is the one that you need to be careful about exposure to sunlight. Okay, thank you guys. Appreciate that. Okay, the next one, back to Dr. Wall about scans. So would your scan show amyloid deposits in wrists and ankles, for etc.? Presumably that carpal tunnels can be caused by ATTR, and would amyloid tissue remain after surgery? And what? So
that's a great question. So the amyloid in those regions is likely to be not very dense, certainly not as much as you'd find in the organ. So the amount of amyloid you have will make it easier to see. But you can design a scan where you image the wrists or the ankles, and you acquired the image for 10 minutes or 20 minutes as opposed to what we do now, and do a sort of an ankle or wrist specific imaging. The data we have from the TTR patients would suggest that that might be possible. So it's not something we've thought about. We have thought about it, but it's not something we're doing routinely.
Okay. And somebody asked for your email address. You mentioned sending them an email. Do you want to put it in the chat, or how do you want one of us to send it out? What would be your preference for that?
If you could send it out to anyone who's interested, that would be fine.
Okay. Muriel or Paula will just put that on our checklist.
I've got all this information. Okay. I've been throwing it out to everyone who asked over the last year or so.
Okay. So we can ask Muriel or ask Paula, and they can get you Dr. Wall's email address. I have one of the Spanish questions. This was about patisiran versus inotersen, and if there was a preference between the two.
Well, we know that the people that make patisiran would have a preference. We know the people that make inotersen would have a preference.
Yes.
And I think it's going to be kind of hard to get a doctor to say one or the other right now, and I don't know that we necessarily want them to. So let's just say that they should talk to their doctor and find out which one their doctor recommends. How's that?
All right, good answer. I have an ApoA1 question. So the 22-year-old son was diagnosed with ApoA1.
22 years old.
Yeah.
Okay.
And watching today, there does not seem to be any medications available to slow the progress. So I want to know if that is correct. And the only treatments are organ transplants. And is there anything we should be looking at right now?
Well, we don't have Dr. Havasi on here.
Yeah, that's what I wondered.
And ApoA1, yeah, we heard about the organ transplants. I don't know of anything, but
I wasn't sure if, I wasn't sure if there's anybody other than Dr. Havasi that could answer
Dr. Picken, can you answer that? You're on mute, Dr. Picken.
Thank you.
There you go.
I'm afraid that if we were to consider question whether there is any specific treatment, then the answer at the present time is no. But we should not discourage the patients from seeking symptomatic treatments and preservation of the renal function for as long as possible. This is not something which is happening overnight. And if you eliminate any other compounding factors, you can increase the longevity of the most affected organ, which would be the kidney. And then in the meantime, maybe more specific treatments will appear. So I think that whatever help can be obtained should be considered, whether it's diet, attention to preservation of the kidney function, other symptoms, etc., cholesterol metabolism. And I am getting beyond my level of expertise here into clinical areas, but I think we need to also emphasize that whatever help can be obtained from these other supportive treatments should not be forgotten.
Thank you.
Okay, I guess we were scheduled till 3, so I'm.
Okay, and we're 2 minutes after. I get the point.
So I want to be fair to people's time.
Okay, we do want to be fair to people's time. We do have quite a few, about 150 or more questions that were answered. We have 46 questions that weren't. So I want everyone who did not have a question answered, if you want to email Paula or at amyloidosissupport.org or Muriel at amyloidosissupport.org, we will send those questions off to our doctors, even some of them who were not on today, if we think it's appropriate, and we will get answers from you. You may not like them, but we'll get answers for everyone, okay? And I know you all want to join me in thanking all of our physicians and scientists for taking time out of their schedule for us, and all of our pharmaceutical people. I admit we're kind of spoiled at the ASG, and we're used to some of these doctors giving up entire weekends and getting on planes and staying in lonely hotel rooms for us and for our patients. But we don't take them for granted. We really don't, and we appreciate them so much. So this is just another opportunity for us to say thank you to all of these wonderful doctors. And as far as having more meetings like this, it does look like we will be having more meetings like this for sure. So you'll be seeing some of these doctors, maybe some new faces as well. If you have specific doctors you would like to see it at our next meeting, please send Paula or me an email again, preferably Paula, because I'm going to have a whole lot of them, right? So Paula at amyloidosissupport.org, and let her know, and then she'll share with me. We get together quite a bit. The most important thing is that we educate and empower our patients, and if we have to do it with virtual meetings rather than face-to-face meetings for a while, that's what we'll do. No one wants to get back on and do the face-to-face meetings more than we do, but for now, that's just not the case. So we thank all of our doctors. We'll let you know when this meeting is available. Give us a week or so. We're new to this, so give us time. And thank you again to everyone, and let's everyone say goodbye.
Bye-bye.
Bye.
Bye-bye, everyone.
Bye-bye.
Bye.
Thank you all.
Thank you.
Thank you very much.
Thank you.
Great. Thank you, all you attendees. We're
Thank you.
ending the webinar. Take care, everybody.
And thank you, the master.
Thank you, Muriel.
Thank you, producer
And
director.
Muriel, the queen of, yes. Thank you.
What a team we have. This is a team effort for sure.